Hi there, and welcome to this very short video podcast around understanding drop-free cataract surgery. I'm delighted to be joined today by Richard Stead, who is a consultant ophthalmologist and also clinical partner with Medica, but also first qualified as an optometrist. But without stealing too much of your thunder, Richard, very, very welcome to this video podcast. Could you just tell
Hello.
us a little bit about yourself and your career?
Yeah, sure. I started out in optometry back in the 90s. I did my pre-reg year, worked in the high street for 3 years, and then went back to do medicine before training up to become an ophthalmologist. And then gained a substantive post in 2015 with a specialist interest in glaucoma. And I started working with Medica in Nottingham in 2022, I think it was, last 3 years. So I've got a bit of a background on kind of most areas of optics, but I think I know how quickly things change. So certainly the background from optics has changed a lot over that time.
It has indeed, Richard. So thank you for that, and particularly with your glaucoma background, it's really interesting to talk about this drop-free surgery because it's not new, but it does have one or two idiosyncrasies. Colleagues watching this will have heard a lot about no drop or drop-free cataract surgery over the last few weeks. Do you mind telling us a little bit about it and the drugs involved, please?
Yeah, sure. So traditionally with cataract surgery, we do the surgery. We used to give a drop of steroid and an antibiotic following surgery. Sometimes they come combined in one drop. Um, there can be problems with drops, patients being able to put them in, reactions to the actual drop, the preservative in the drop, etc., which aren't infrequent. Over time, the evidence has evolved that we know now that we don't have to give antibiotic drops after surgery because we give an injection during surgery. And then the drop-free surgery really is referring to the administration of steroids. Because at the moment, in the majority, we give steroid drops just to help reduce the inflammation after surgery. With drop-free surgery, a depot injection of a steroid is given to reduce inflammation without the patient have to put in drops. So it's clearly got benefits. It's much more convenient for the patient. It doesn't matter about their dexterity of getting the drops in. The drug that's commonly used, because we've been doing this for some time, is triamcinolone, which is a steroid that we inject under the conjunctiva at the eye at the end. There are other preparations. Some are available in America where they actually inject the steroid into the eye. But I think in this country, the ones we've got the most experience with is triamcinolone, which is, I say, just a depot steroid injection at the end of surgery.
Now, it's not new. It sounds really useful for a certain cohorts of people. Who are the types of people who really benefit from that?
Yeah, well, we've been doing it some time. Generally, we do it if people are going to have problems with administering the drops post-operatively. So sometimes with learning difficulties, particularly in the trust, if we have to do someone with under a general anaesthetic and we can't put drops in. Sometimes with dementia. Sometimes if there's going to be other problems with adherence for whatever reason, we can give this injection and it works very well. And we tend to do it on an ad hoc basis as to, we assess the patient and we administer it if we feel that we need to. And, usually that's in consultation with the patient as well regarding whether they'll be able to use drops or not.
So it's great to hear Medica use this, trusts use this. Lots of people use this where it's really, really required, and that depends on the idiosyncrasies of that particular patient. What are the potential pitfalls of this approach then?
Well, the big problem with it is, and it keeps me in a job, it's glaucoma. And we know there's an association between steroids and glaucoma. And we know, or intraocular pressure, we know roughly between 5 to 10% of the population, if you give them steroids, the eye pressure will go up. In the majority, it goes away when you stop the steroids. So if they're having drops, it's quite easy. You stop the drops and the pressure gradually reduces down. In some, it doesn't. And the problem with the depot injection, it's very difficult. You can't stop the depot. The only thing you can do is take them back to theatre and wash it out if needs be, but that isn't always effective. So the real difficulty is this steroid response, because if they have a high pressure, the patient won't know. And one of the problems is picking up the patients that have the pressure response. So traditionally or usually the pressure response will happen anytime between 1 to 4 weeks, but it can be longer. So the evidence at the moment suggests that if we're going to give steroids, we probably need to surveil that patient a little bit more closely, just to watch and see if we pick up a pressure spike that the patient wouldn't realize is there. And the problem with it being, if they had a follow-up after cataract surgery after 4 weeks, it might still miss where that pressure spike is. So glaucoma is again the kind of the hidden danger here.
And given that as many as 10% of the population could be steroid responders, and very rarely do they know, it's only if they've had it and that they've
Yep.
had an issue before, it seems like there needs to be quite a considered approach to using the drop-free solution on large cohorts b before there's further study done on it.
Yeah, well, it's the same for any surgery, isn't it? And be it kind of orthopedic surgery, ophthalmic surgery, cataract surgery, for example, we always inform the patient of the risks and benefits. And I always tell them, just imagine a set of kind of balance scales. On one side, you've got the risk. On one side, you've got the benefit. The benefit of this, it might be more convenient for them. They might get lower complication rates. Okay. The risks are having a high pressure or glaucoma. The problem is it's quite difficult to quantify that risk at the moment because we don't actually know what those risks are from a blanket policy of giving everyone the steroids. So if you've already got glaucoma, there's a family history of glaucoma, you're myopic, short-sighted, there's a higher risk of having that pressure response. And there's probably a need to be surveilled a bit more frequently. The problem is we don't have that high quality evidence to tell us who needs to be followed more frequently. It's in the pipeline, the studies are ongoing. But so far, all the evidence is what we call retrospective cohort studies, which don't actually categorically answer the questions. And medicine's kind of littered with this in the literature, where we've done one particular approach with medicines. There's been a big trial, and that's completely changed how we go. Certainly, in my time, we had an issue with steroid administration after traumatic optic neuropathy. There was a big trial that suggested super high dose steroids were appropriate for traumatic optic with traumatic spine lesions. So they changed the practice and gave people very high doses of steroids. And then there was a big randomized trial which showed actually that was more dangerous than not having the steroids at all, because the mortality associated with the steroids increases the morbidity and mortality. So that's something that went away. And we know from things like controversial things like the MMR vaccine in the past, some of the results from very small trials were kind of well spread in the literature, but actually when you look at the very robust evidence, that completely changed the view towards those treatments. So I think there's a real need to wait for methodologically sound trials before we start kind of blanket treating people, because we need to inform them of the risk as well. We've been doing this for years, probably 20 years plus in the trust and things, but it's always on a kind of a very considered basis, not kind of a blanket policy, which we just don't know how many are going to respond to the steroids and how many might go on to need glaucoma. And one of the real problems is it's not straightforward then, because most people with glaucoma are asymptomatic. They don't know they've got it. Okay. So in theory, if you just follow someone up, say after 4 weeks, and have a pressure spike after, and they don't see their optometrist for another year, there could be a year with a very high pressure. And then it becomes very difficult to treat because you can't reverse that damage. So that's the kind of detail that we need to go into before we can start advocating that for treating everyone.
Thank you, Richard. I was speaking to Nigel Kirkpatrick, who's medical director and a fellow consultant ophthalmologist at New Medica, and he said with this option, you can't get off the bus easily. Whereas with a drop-based cataract surgery, you can simply remove the steroid or if they finish the course, the pressure will drop back down to normal in the overwhelming majority of cases. So what would be your message to optometrists and other people in the sector watching this?
I think it's be aware of the risks and benefits. I suppose you need to kind of inform the patients. We can perform dropless cataract surgery if it's appropriate. It may be that after that surgery that we might need to surveil them a bit closer. They need to be warned of the risk of glaucoma as well if they've had that. So it's certainly going to be appropriate for some. It might even be the majority, but we need that evidence before we can start to advocate that for everyone. I mean, we have glaucoma clinics in New Medica. It's not just cataracts that we do. So it may be that we have to just monitor people a bit more closely. But we always base a treatment on the individual patient, and if it's appropriate, we can do that. But it might not be appropriate for all. We just don't know. We just need the evidence first.
Thank you, Richard. What I'm hearing as an optometrist is it's all about consideration. There might be a small number of patients who really benefit from this for the reasons that you've mentioned there. People with Parkinson's and that kind of thing as well would come into it, as well as the great examples you've given. And if you are making a referral and you feel someone might benefit or might struggle to put drops in for whatever reason, let it be known. And someone like Richard or other consultant ophthalmologists will make that part of weighing up that risk of balance versus benefit for that individual. Put it on your referral, but don't forget also the importance of offering people a choice when it comes down to their referral. As optometrists, we all know the College of Optometrists have got guidance on this, and there's lots of things to consider as ever. One of those being location, length of time, quality of service, clinical outcomes, a whole host of them. But it's also really important to consider the type of intraocular lens that's being used as well, which is something that we don't often do. And actually lots and lots of different idiosyncrasies with those intraocular lenses used by different providers. Richard, thank you very much for your time, and hopefully we'll speak again soon.
Thanks for talking to me. Thanks, Paul.